Good morning, everyone. Today, we are going to learn about Section 3, Dislocation of Shoulder Joints in Chapter 59, Injuries of Upper Limb, Bones, and Joints. All of you need to master the knowledge of this section. Dislocation of the shoulder joint. First, let's look at the definition. The motion of the shoulder joint involves the following joints: the glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint, the scapulothoracic joint. The motion of the glenohumeral joint is the most important. The dislocation of the glenohumeral joint is usually called the shoulder joint dislocation, which ranks the first place among dislocation of human joints. Next, let's review the anatomy. Why is the shoulder joint most prone to dislocation? Which direction will it dislocate? Next, let's take a look at the characteristics of this shoulder joint. First, the scapular glenoid is relatively shallow. The joint capsule is thin and relatively loose, and the range of joint motion is large, which is also evolved due to more use of our upper limbs. It stabilizes itself relying on the peripheral muscles and ligaments. Let's take a look at the shape of the shoulder joint. Let's look at this picture. The upper part of the shoulder joint is relatively full, with the protection of the rotator cuff, and the lower part is relatively empty with weak protection, so it is easy to dislocate downward. We just mentioned the concept of rotator cuff, and then what is a rotator cuff? What is the function of it? What does it consist of? It is actually the muscles around the shoulder joint, which is made of the supraspinatus, infraspinatus, teres minor, and subscapularis. The supraspinatus, infraspinatus, teres minor, and subscapularis form a cuff attached to the proximal end of the humerus, forming an important structure to stabilize the shoulder joint. Such structure is often injured due to the dislocation of the shoulder joint. What other nerves and blood vessels pass through the shoulder joint besides the muscles? Will they be injured after dislocation? Let's take a look at the anatomy. The brachial plexus and the subclavian arteries and the veins pass through the medial coracoid process, as well as the axillary nerve, which control the motion of the deltoid and the sensation of the peripheral skin after separating from the brachial plexus. Clinically, the axillary nerve may be injured sometimes after the dislocation of the shoulder joint, and the possibility of vascular injury is relatively small. Therefore, we need to check whether the axillary nerve is also injured after the dislocation of the shoulder joint. Well, after we have reviewed the anatomy, let's talk about the causes of dislocation of the shoulder joint and clinical classification of it, which is conducive to our clinical learning. First of all, let's talk about the causes. Trauma is the main cause, mostly indirect force. When the upper limb falls in an abduction and extension position or is hit, the forces passes through the head of the humerus to the shoulder joint, so that the head of the humerus is dislocated by breaking through the joint capsule. It is divided into anterior dislocation, posterior dislocation, superior dislocation, and inferior dislocation, according to the dislocation direction of the head of the humerus. Anterior dislocation is most common. After dislocation, the location of the head of the humerus may be subclavian, subcoracoid, anterior shoulder, and subglenoid. In fact, subglenoid dislocation is most common clinically. Therefore, the subglenoid dislocation in the anterior dislocation is most common. We can look at the anterior dislocation and posterior dislocation in the example pictures. Let's look at the picture on the left first. It is the typical anterior dislocation. The subglenoid dislocation on the right side is the posterior dislocation of the shoulder joint. Although it is not common clinically, it is easy to be omitted in diagnosis because such patients are often patients with epileptic attack or electric injury. If you encounter such patients at such time, you must be careful when they come. Now, let's talk about the clinical manifestation after discussing the causes. What are the clinical manifestations and how to diagnose them? In fact, when the patients come, if he has a history of abduction, extortion, and injury by a fall onto a backward stretched arm with pain and swelling, a dyskinesia in the shoulder, the typical manifestation is a square shoulder deformity. As shown in the picture, upon physical examination, we can see that there is a sense of emptiness at the scapular glenoid. There is a square shoulder deformity, and the dynamic fixation will occur in the upper limbs. Why will dynamic fixation occur? Because our shoulder joint is not in the normal position after injury, and it will be very painful. A good limb will be used to support the affected limb at this time, which is called dynamic fixation. Clinically, we can also detect positive Douglas sign. Douglas sign is a very typical sign that can definitely diagnose shoulder joint dislocation. Normally, we can touch the contralateral shoulder with the unaffected arm, and our elbow joint can be close to our chest wall. Positive Douglas sign means that we can touch the contralateral shoulder, but the elbow joint cannot be close to the chest wall, or just the opposite. The elbow joint is attached to the chest wall, but we cannot touch the contralateral shoulder with the hand, which is called positive Douglas sign. Then we also need to examine the nerve function and blood supply of the patient at this time to understand the sensory motor and the blood supply of the distal end of the affected limb. Next, after the physical examination has been completed, we need to perform the corresponding auxiliary examinations to confirm whether there are some corresponding fractures and so on. That is the routine X-ray examination that we need to do. If it is necessary for us to understand, we can do CT reconstruction and magnetic resonance imaging to understand the situation of rotator cuff injury. When we treat a patient with shoulder trauma who has a definite history of shoulder trauma, the above-mentioned clinical manifestations and corresponding signs of square shoulder deformity and emptiness at the glenoid fossa, we can completely diagnose shoulder joint dislocation in combination with corresponding auxiliary examinations such as X-ray film, so it is relatively easy to diagnose. Next, let's see the treatment. The preferred method is manual reduction plus external fixation. The reduction method is called Hippocrates method. In fact, it is called the method of hand holding and foot kicking. This method is relatively easy to master. So, how to do that? For example, if the patient is dislocated on the right shoulder, then we shall stand on the right side of the patient and put your right foot in the armpit of the patient, and then the assistant will work with you to pull his right upper limb together. We can watch a video later specifically. In fact, these reductions are relatively simple, but what else shall we pay attention to at this time? Especially in the elderly, we need to take an X-ray film. The answer is yes. Everyone knows that the aged people may have osteoporosis. Fractures may occur at the same time after dislocation of the shoulder joint. With an X-ray film, the fracture site and the specific shape can be confirmed, and advance notice and precautions after operation can be given. Clinically, We may also encounter young people who are physically strong, so the reduction may not be successful. At this time, we may need to perform reduction under anesthesia to avoid serious collateral injury caused by nerve traction. After a successful reduction, what else should we do? Ask the patient to go home directly, or shall we immobilize it? How long does it take to immobilize, and how to immobilize it? The answer is yes. Immobilization must be done. Generally speaking, we usually immobilize it for 3 to 4 weeks in case of a patient without a fracture. In case of a patient with a fracture, it is recommended to extend the immobilization time. It is generally immobilized for 5 to 6 weeks. Forearm band and shoulder band are used for immobilization. If the fracture reduction is not satisfactory, we may also consider surgical treatment at this time. After the fixation, the active fist clenching on the forearm can be performed in the early stage. In the later stage, we need to perform functional rehabilitation exercise for the shoulder joint after the immobilization time is sufficient. Otherwise, serious shoulder pain and other sequelae may occur during the motion of the shoulder joint. So, are all patients treated conservatively? I just mentioned that the surgery is required sometimes, right? Next, let's see which patients need surgical treatment and what are the surgical indications. For example, dislocation of the shoulder joint with a complication of nerve injury, which is often posterior dislocation and will be missed. Surgical treatment is required for most of them in later stage. Okay, let's summarize the main concept of this class. We have learned the direction of dislocation of shoulder joints, typical clinical manifestations, diagnosis, and treatment principles, all of which need to be mastered. That's all for today's class. Thank you.